Welcome to Essentials in Trauma Care in the Geriatric Population in a Disaster Setting. My name's Barry Platnick. I'm the Director of the Surgical Intensive Care Unit at Denver Health. I'm also a trauma and acute care surgeon here as well. And I've previously been the Trauma Medical Director at Denver Health, as well as several other hospitals in the Denver metro area. These are the disclosures. And I have no financial conflict of interest. However, I want to point out there is a paucity of published real-world data examining the effect on patient care and clinical outcomes of elderly-specific triage criteria. Similarly, in the management of the geriatric patient. I will be presenting my understanding of the current data as well as my approach to the management of the geriatric trauma patient with special focus on the disaster setting. The first thing I want to point out is that initial trauma care in the geriatric population is nearly identical to that of the non-geriatric adult population. In other words, airway, breathing, circulation, disability, environment, and exposure are essentially the same and certainly prioritized basically the same, whether this is a younger or older trauma patient. However, geriatric patients must be recognized in order to treat them differently. The initial assessment does need to be tailored. Initial care will have some additional considerations, and maybe most importantly in the disaster setting, after field triaging that geriatric patient to transport to a facility with multidisciplinary capabilities will be the best predictor of risk-adjusted survival and decreased disability for this group. In other words, once the decision to transport has been made, the destination does impact their overall survival and disability. It's important to recognize that we'll all be taking care of more older patients as time goes on. As you can see, the 15-year period between 2020 and 2035 expects a 5 to 7% increase in people between the ages of 60 and 80. That's 20 million new elderly patients. Defining geriatric can be difficult, and numerous institutions use different approaches to doing this. However, I think most people at this point recognize that age alone is not the best predictor, and comorbidities and frailty is a useful adjunct and important in helping us identify patients at risk. If you look at this frailty score, you can see that simply by looking at the patient and their surroundings, you can get an assessment of who is not frail, minimally frail, or very frail. And the breakpoint comes in patients who are moderately frail or more, and those patients may experience increased morbidity and mortality associated with their injuries when compared to a less frail group. Looking at the patient and their surroundings, and if possible, speaking with the patient or people in the area may give a good indication as to their level of frailty. Advanced directives can also help us in the pre-hospital setting and certainly in a disaster setting. Many patients have advanced directives, and that advanced directive can be found frequently in the home and often, as you can see, on the refrigerator or door. This document may specify what the patient would or would not want done and who they would want to make decisions for them should they be unable to make decisions for themselves. This will help in providing care for patients that they would want and not providing care for patients that they would not want. In Colorado, we have two specific documents that are important to recognize. One is the CPR directive, which is a physician-signed document stating that that patient would decline CPR and therefore should not receive CPR in the field. Additionally, the Colorado Medical Orders for Scope of Treatment, or MOST form, delineates more specifically what a patient would or would not want. This is a binding document and is in fact a physician order, which can be enacted in the pre-hospital setting. The Trauma Quality Improvement Program by the American College of Surgeons is a useful document to refer to, and some of what I will be speaking about is an adaptation from this document. During the initial evaluation of the geriatric patient, We need to know that late recognition of injuries might be due to pre-existing neurocognitive disorders. This can result in an alteration in the ability to examine the patient with respect to mental status, and it may mask or may augment the diagnoses of traumatic brain injury. Altered baseline vitals can also impact the initial evaluation. We'll speak a little bit more about that, but geriatric patients are frequently hypertensive, and this can impact our assessment. Also, medications will impact the ability to evaluate the patient, and we'll speak more about that in the next slides. It's important, of course, to recognize that all of this can result in under-triage. In other words, under-recognizing injuries in a patient who may be more injured than you think they are. We must over-triage when possible, and some patients, especially our older patients, don't give you a second chance. Maintain a high index of suspicion in geriatric patients. Just take that extra second. Recognition of early impending shock in the geriatric patient requires a special increased index of suspicion. One of the things we know is that geriatric patients are typically hypertensive and often have decreased oral intake. Both of these things can result in volume contraction, leading to an overall decreased circulating volume in the patient. As a result, you need to pay attention to vitals in a slightly different way than in the younger patient. In a younger patient, you may consider less than 90 an abnormal systolic blood pressure. However, in the elderly patient, a systolic blood pressure less than 110 needs to increase your index of suspicion, as does an increased heart rate greater than 90. These should be considered potentially abnormal in this group. The shock index, which is the heart rate divided by the systolic blood pressure, can also be integrated into the trauma, into the approach. The shock index, which is the heart rate divided by the systolic blood pressure, can also be integrated into the initial evaluation of the trauma patient. A shock index greater than 1 reliably predicts increased mortality. Depending on the circumstances, this may impact decision to transport or initial approach. The primary survey also has special considerations. While the importance of moving from airway through environment and exposure is the same as it is with the adult non-geriatric trauma population, special considerations such as loose or missing teeth, inability to open the mouth due to contracture at the jaw, or cervical spine immobility or osteophytes can result in difficulty with intubation or management of the airway with bag mask ventilation. Baseline hypercarbia and altered PFTs in diseases such as COPD may impact the patient's breathing and may impact not only the ability to oxygenate the patient, but can result in decreased respiratory drive in a patient otherwise breathing spontaneously due to loss of the hypoxic respiratory drive that may be associated with this disease by delivering increased oxygen. And the take home there is with patients who have COPD, you may need to limit the amount of supplemental oxygen. Circulation, when evaluating circulation, home meds, baseline hypertension, and congestive heart failure, as we've spoken about, need to be considered. These conditions can result in both hypovolemia and hypervolemia. When assessing the disability, cognitive and neurological disorders, such as the neurodegenerative disorders and movement disorders, may confound the ability to identify traumatic brain injury or decrease mental status due to shock. When considering environment and exposure, the fragile skin in the elderly patient, as well as cachexia and hypothermia, need to be considered. Patients need to be padded in considering the possibility of pressure ulceration due to prolonged immobility, and they need to be kept warm due to the decreased ability to thermoregulate associated with older age. We need to recognize that these classes of medications also affect initial care. Anticoagulants and antiplatelet medications clearly can lead to increased bleeding and bruising. This may result in the need for more extensive measures for external bleeding, but also increased index of suspicion for solid organ injury bleeding, retroperitoneal bleeding, as well as bleeding associated with fracture. Beta blockers and antihypertensives may confound the interpretation of the vital signs. Hypoglycemics and psychoactive medications may impact the ability to interpret the patient's mental status, and they may also lead to altered hemodynamics due to either over or underuse. Considering common comorbid conditions during the secondary survey is important because they can mimic or mask injuries. Acute coronary syndrome, for instance, or pneumonia, for instance, may cause severe chest pain, which might be misinterpreted as sternal or rib fractures. Hypovolemia and dehydration, as we have discussed, can impact the vital signs. Urinary tract infection can impact the mental status evaluation or may mimic an acute abdomen. Chronic renal failure will impact the medication dosages for certain medications. Pre-existing cerebrovascular event may also present as a motor deficit that looks to be associated with a fresh injury such as brain injury or spinal cord injury. And syncope at the time of the injury may be either the etiology or a secondary etiology in a disaster setting. Certain medications that we use in the pre-hospital setting require special considerations. As you can see from this chart, dosage adjustment needs to be made for some, but not all of these medications. The benzodiazepines and opioids require decreased dosages. Etomidate requires a decreased dose. Notably as well, neuromuscular blockade, whether non-depolarizing or depolarizing, does not require any change in dosage. These are special considerations when evaluating the patient with traumatic brain injury in the geriatric population. Severe traumatic brain injury carries a higher mortality in the geriatric population. Some of these considerations may impact decision to transport. Smaller changes in GCS equate with higher odds of mortality in geriatric patients. In other words, mild and moderate traumatic brain injury have a higher mortality in the geriatric patients than it would in a younger population. GCS is the best predictor of survivability and disability in the field. Loss of gag or pupil response and or a GCS less than 5 carry exceptionally high mortality in the geriatric population. And again, this might be considered in the decision to transport in a disaster setting. Pitfalls in the geriatric population include, as we've discussed, medications, medical conditions, pre-existing neurocognitive disorders, and sensory impairment, such as hearing impairment. It's important to recognize that many patients who appear to have decreased mental status may simply have visual or hearing loss. Special considerations for axial skeletal injuries in the geriatric population are as follows. First, injury identification is no different than it is in the non-geriatric patients. Physical examination for tenderness and for deformity along the vertebral spines is the same, and the sensory and motor examination is the same. However, there are some triage considerations. Spinal cord injuries in geriatric trauma patients carry an in-hospital mortality of greater than 40%, with increasing mortality with a higher spinal cord level. In other words, it's important to recognize that when triaging these patients, spinal cord injury as well as how high the spinal cord injury is, might impact the decision to transport. Intubation due to high spinal cord injury should be considered a relative contraindication for transport during a mass casualty incident due to the exceedingly high mortality. Again, when considering transporting a geriatric patient with spinal cord injury, the need to intubate as well as level of spinal cord injury are considerations in the decision to transport. In summary, initial management of the geriatric trauma patient is nearly identical to the non-geriatric adult patient. However, a high index of suspicion and geriatric parameters for shock should help guide the evaluation and the treatment. Indications of frailty may, and I would submit, are more predictive than chronological age. Always consider advanced care planning documentation in decisions for treatment and transport. Comorbid conditions and home medications impact treatment decisions and patient outcomes, and therefore, any opportunity to identify these at the scene should be made. Hearing and visual impairment should be considered during evaluation, whether evaluating for brain injury or mental status changes, or simply evaluating the patient for as a whole. Speak slowly, speak clearly, and speak loudly. Medication adjustments may be needed. If the decision to transport has been made, the patient should be transported to a facility that has the capabilities to provide multidisciplinary advanced care for the geriatric patient. This is the best predictor of survival and decreased disability. Liberal use of CT scan for brain, spine, chest, abdomen, and pelvis is warranted. I refer you to the American College of Surgeons Best Practice Guideline in Geriatric Trauma Management, as well as the American College of Surgeons Trauma Quality Improvement Program Best Practices Guideline. Thank you for listening to this presentation.